program is for educational purposes only and reflects independent editorial commentary. It is not medical advice and should not replace clinical judgment or review of primary sources and guidelines. The views expressed are those of the host and contributors.
Welcome back to EP Edge Journal Watch. I'm Dr. Sharma. Thank you as always for listening, for reading, and for the thoughtful suggestions many of you have sent in. This episode is a special HRS 2026 edition focused on one trial that is already generating a lot of conversation, AVANT GUARD. The trial asks a very important question. In treatment-naive patients with symptomatic persistent atrial fibrillation, should we move earlier toward pulsed field ablation as initial rhythm control therapy rather than starting with antiarrhythmic drugs? The headline answer is yes, at least for the selected population studied. Pulsed field ablation roughly doubled the chance of freedom from atrial arrhythmia at 12 months compared with antiarrhythmic drug therapy. The reported number was 56% with PFA versus 30% with antiarrhythmic drugs, with a hazard ratio of 0.46. But this is exactly the kind of trial where the headline is not enough. For this episode, the trial's manuscript and the supplemental material were evaluated in depth. That matters because several of the most clinically important details are not captured by the abstract alone. The trial was paused during enrollment after neurological events. The protocol was tightened. The final enrolled population became narrower than the population that originally entered the trial. The antiarrhythmic drug comparator excluded amiodarone by design, and the positive efficacy result depends heavily on continuous monitoring and on a non-traditional asymptomatic recurrence threshold. None of that invalidates the result, but it does change how we should explain the result to patients, fellows, APPs, and referring cardiologists. So today, we will walk through why the trial was done, how it was designed, what the primary efficacy and safety results mean, what happened with the study, pause, how to interpret the statistics, and finally the EP Edge take, how this trial should and should not change practice. Let's start with the rationale. Persistent atrial fibrillation remains one of the hardest rhythm control populations we manage. Drug therapy can work, but it often requires cardioversion, dose adjustment, hospitalization for initiation, and eventual escalation to ablation. Catheter ablation can reduce arrhythmia burden, but historically, the question has been whether it should be used early in persistent AF, particularly before a patient has failed an antiarrhythmic drug. Pulsed field ablation changes that discussion because it offers a non-thermal ablation modality with a potentially favorable tissue selectivity profile. The clinical question is no longer simply, can ablation work after drugs fail? The more contemporary question is, should ablation be considered as the initial rhythm control strategy in selected patients? AVANT GUARD enrolled patients with treatment-naive symptomatic persistent atrial fibrillation. The AF duration had to be continuous for 7 to 365 days. Patients were randomized 2-to-1 to pulsed field ablation using the Farapulse pentaspline catheter or to a Class 1 or Class 3 antiarrhythmic drug strategy. Importantly, amiodarone was excluded as a first-line comparator. The randomized part included 310 patients, 207 assigned to PFA, and 103 assigned to antiarrhythmic drug therapy. Every patient received a LuxDX implantable cardiac monitor, which is crucial. This was not a trial relying only on symptoms, office ECGs, or intermittent Holters. Continuous monitoring shaped the endpoint. There was also a second part to the study. After the randomized sample size was met, the protocol enrolled an additional 100 patients assigned to PFA for safety analysis only. These patients were not part of the randomized efficacy comparison. They were added to increase the total PFA-treated cohort for the primary safety endpoint. This is one of the key structural points in the trial. AVANT GUARD is really two studies inside one protocol. Part A is a randomized superiority trial testing PFA versus antiarrhythmic drugs for efficacy. Part B is a single-arm PFA safety cohort compared against a pre-specified performance goal. That means when we say the serious device or procedure-related adverse event rate was 5.1%, we are not describing a direct randomized comparison against drug therapy. We are describing a single-arm PFA safety result tested against a 12% benchmark. That distinction matters when we counsel patients. Now let's go to the primary results. The primary efficacy endpoint favored PFA. At 12 months, freedom from the composite efficacy failure endpoint was 56% with pulsed field ablation and 30% with antiarrhythmic drug therapy. The hazard ratio was 0.46, with a 95% confidence interval from 0.33 to 0.65, and a p-value less than 0.001. In practical terms, a hazard ratio of 0.46 means the PFA arm had about a 54% lower hazard of reaching the composite failure endpoint over follow-up compared with the drug arm. The confidence interval is fairly tight and does not cross one, so statistically, this is a robust efficacy result. The p-value tells us that the probability of seeing a result this extreme by chance, if there were truly no difference, is very low. But the key phrase is composite failure endpoint. The composite included several ways to fail: amiodarone use, electrical cardioversion, repeat ablation, detected arrhythmia recurrence, and, for the PFA arm only, use of class 1 or class 3 antiarrhythmic drugs. For arrhythmia recurrence, symptomatic episodes of 30 seconds or longer counted. Asymptomatic episodes counted only if they lasted at least 1 hour. The primary safety endpoint was also met. In 257 PFA-treated patients, the device or procedure-related serious composite adverse event rate was 5.1% at 12 months. The upper boundary of the 97.5% confidence interval was 8.6%, which beat the pre-specified 12% performance goal. That is a positive safety result by the trial's design. But again, it is not a head-to-head safety comparison against antiarrhythmic drugs. It is a comparison against a fixed historical benchmark. Arrhythmia burden also favored PFA. Median post-blanking atrial arrhythmia burden was 0.0% with PFA, compared with 0.3% with antiarrhythmic drugs. Mean burden was 3.4% with PFA and 9.9% with drug therapy, a difference of minus 6.5 percentage points. The EP edge take at this stage is straightforward. AVANT GUARD shows that first-line PFA reduces detected AF burden in selected treatment-naive persistent AF patients. The burden signal is real. The efficacy result is statistically strong, but what that means clinically depends on how the endpoint was constructed and what patients actually felt. Now, we need to talk about the study pause. On October 18, 2024, after 6 neurological events in 215 PFA procedures, the Data Monitoring Committee paused enrollment. 2 independent neurologists reviewed the events. 5 were classified as cardioembolic, and 1 was classified as air embolism associated with the Faradrive deflectable sheath. All were minor strokes, with NIH stroke scale scores below 5, and all patients recovered or improved. Several details matter here. 5 of the 6 neurological events occurred in women. 4 of the 5 embolic strokes occurred in patients with CHA2DS2-VASc scores of 4 or higher. None of the 6 patients had prior stroke or TIA. None had heart failure or vascular disease. Also important, 3 of the 6 were on uninterrupted or near uninterrupted DOAC therapy at the time of the event. One particularly important case was a 74-year-old woman on uninterrupted dabigatran with an intraprocedural ACT greater than 350 seconds who still had an embolic event. That matters because the post-pause protocol mandated exactly that kind of best practice anticoagulation and ACT management. In other words, the revised protocol addressed risk, but it did not eliminate uncertainty. After the pause, protocol version F tightened several key elements. Patients with CHA2DS2-VASc scores of 4 or higher were excluded from PFA randomization and PFA assignment. Pre-procedural imaging was tightened to require TEE or CT within 24 hours of the procedure. Intracardiac echo alone was no longer sufficient. Anticoagulation had to be uninterrupted for at least 4 weeks before the procedure. Any missed dose, including the day of the procedure, delayed the case. A CT greater than or equal to 350 seconds was required before the first PFA application and had to be maintained until all devices were removed from the left atrium. These changes improved procedural discipline, but they also changed the trial population. The CHADS-VAS exclusion removed about a quarter of the eligible pre-pause population. Female enrollment decreased. Diabetes and hypertension became less common. Mean CHADS-VAS score fell. So the trial that finished was not exactly the trial that started. The EP edge take is this: the pause was handled transparently and appropriately, but the post-pause safety result applies to a narrower, lower-risk population. It should not be generalized automatically to older, higher-risk persistent AF patients with more comorbidity. The next question is, how did patients fail? This is where the composite endpoint becomes clinically important. Symptomatic recurrence as the first failure mode was uncommon in both arms and was nearly identical, 1.9% with PFA and 2.9% with antiarrhythmic drugs. That is the most important number hiding underneath the headline. Patients did not primarily separate by symptomatic recurrence. They separated by monitor-detected asymptomatic recurrence and by treatment escalation. Asymptomatic atrial arrhythmia lasting at least 1 hour was the first failure mode in 30.4% of PFA patients and 45.6% of drug-treated patients. Non-protocol ablation also occurred more often in the drug arm. About 1/3 of patients assigned to antiarrhythmic drugs eventually crossed over to ablation during the trial. So when people say PFA worked almost twice as well, that statement is technically defensible but clinically incomplete. The main advantage was not that patients felt dramatically better. The main advantage was that continuous monitoring detected less AF. The conventional endpoint in AF ablation trials has often been symptomatic or documented atrial arrhythmia recurrence of 30 seconds or longer. AVANT GUARD used a different structure, 30 seconds for symptomatic recurrence, but 1 hour for asymptomatic recurrence. The manuscript reports freedom from symptomatic recurrence alone at 90% with PFA versus 87% with drugs. That is only a 3-point absolute difference, and the confidence interval crosses 0. In plain language, if this trial had been judged only by symptomatic recurrence, it would not have shown a statistically significant difference. But the 1-hour asymptomatic threshold was pre-specified, and it was not arbitrary. The rationale comes partly from data suggesting that AF burden measured by continuous monitoring correlates with downstream healthcare utilization and clinical relevance. The concept is reasonable. More AF burden may reflect more active atrial disease. The supplement also helps. Across different asymptomatic thresholds from 2 minutes to 1 hour, 6 hours, and 24 hours, the efficacy gap remained around 20 percentage points. So this was not a cherry-picked 1-hour threshold creating a result out of nothing. The burden signal holds. The EP edge take is nuanced. The burden reduction is real and reproducible. But whether that burden reduction translates into better long-term outcomes, such as fewer strokes, less heart failure, less dementia, or lower mortality, was not tested in a meaningful way at 12 months. Now let's talk about quality of life. This is one of the most clinically relevant parts of the trial because it connects the statistical endpoint to the patient sitting in front of us. Both groups improved. The A-Fib score improved by 23.3 points with PFA and 19.8 points with antiarrhythmic drugs. Both changes exceed commonly cited thresholds for a clinically meaningful improvement, but the between-group difference was only 3.6 points, with a confidence interval from -1.8 to +9.0. That means the trial did not show a statistically significant quality of life advantage for PFA over drug therapy at 12 months. The same was true for other patient-reported and cognitive outcomes. EQ-5D3L did not significantly separate. Cognitive testing and depression inventory measures did not significantly separate. This does not mean PFA failed. It means the type of benefit detected by the trial was different from the type of benefit many patients expect when they hear that a procedure worked better. The trial shows less AF burden with PFA. It does not show that patients felt substantially better with PFA than with drug therapy inside 1 year. That distinction matters in counseling. If a patient says, Doctor, will I feel better with ablation than with medication? AVANT GUARD does not prove that answer is yes. If the patient says, will ablation reduce the amount of AF my heart has, including episodes I do not feel, then the answer from this trial is yes in the selected population studied. The trial also did not directly analyze whether patients with lower post-treatment AF burden had better quality of life within each arm, so we should be careful not to overinterpret the patient-perceived data. The EP-EDGE take, both strategies improved how patients felt. PFA did more to suppress detected arrhythmia burden. At 12 months, those two facts did not translate into a clearly superior patient-reported outcome for PFA. The long-game argument for burden reduction remains plausible, but AVANT GUARD does not prove that long-game outcome. Safety deserves a balanced discussion. The PFA serious device or procedure-related adverse event rate was 5.1% and met the pre-specified performance goal. The serious events included 6 strokes, all before the protocol pause, 2 vascular access complications requiring intervention, several pulmonary edema or procedure-related heart failure events, 1 heart block requiring permanent pacemaker, and 2 cardiovascular events including sinus bradycardia and cardiogenic shock. But the antiarrhythmic drug arm was not benign. Total adverse event burden through 12 months was very similar between groups. Serious adverse events were 21.1% in the drug arm and 21.1% in the PFA arm. That is a clinically important result. The usual framing that drug therapy is safer, easier, and lower touch is not what this trial showed. Of the patients who started antiarrhythmic drug therapy, about 1 in 5 were hospitalized to initiate the drug. Nearly 2/3 required at least 1 electrical cardioversion. More than 1/3 required dose titration, and about 1/3 eventually crossed over to ablation. Now, the comparator arm also needs scrutiny. Amiodarone was excluded as first-line therapy. That is defensible from a guideline and toxicity standpoint, especially if we are talking about initial treatment in many patients. But amiodarone is also the most effective antiarrhythmic drug for persistent AF. By excluding it, the trial compared PFA against a drug strategy that reflects common practice, but not necessarily the strongest possible pharmacologic rhythm control strategy. The drug mix included flecainide, sotalol, dofetilide, and smaller numbers of other agents. For persistent AF, that comparator is clinically realistic in some settings, but it is not the maximal antiarrhythmic strategy. There is also the funding and authorship context. The trial was funded by Boston Scientific, and the analysis was conducted according to the statistical analysis plan. Several authors were Boston Scientific employees, and many investigators disclosed financial relationships with the company. This does not invalidate the data. Industry-sponsored device trials are common in electrophysiology, and independent committees reviewed key safety events. But readers should know the funding structure, the disclosure profile, and the fact that patient-level data are not being made available for independent reanalysis. The EP-EDGE take, the data are credible, but they should be read with the same rigor we apply to any major industry-sponsored device trial. So how should we use AVANT GUARD in practice? For a treatment-naive patient with persistent AF, recently diagnosed, CHA2DS2-VASc less than 4, preserved ejection fraction, left atrial size less than 5.5 centimeters, no major comorbidity, and a willingness to accept procedural risk, first-line PFA is a reasonable strategy. For that patient, the trial supports saying this: ablation gives you a higher chance of being free from detected AF at 1 year compared with a non-amiodarone antiarrhythmic drug strategy. It also reduces AF burden. The best estimate from the randomized comparison is about 56% freedom from the composite failure endpoint with PFA versus 30% with drugs. But I would avoid telling the patient that PFA simply works twice as well. That oversimplifies the trial. A better statement is PFA roughly doubles the chance of being completely free from detected AF at 1 year, but both groups felt similarly better, and both strategies carried meaningful medical risk. For an older patient with CHA2DS2-VASc 4 or higher, prior stroke or multiple comorbidities, the evidence is less direct. These are often the patients in whom rhythm control matters most, but they are also the patients made less visible by the post-pause protocol. AVANT GUARD does not prove that first-line PFA has the same risk-benefit balance in that group. For women, the discussion should also be honest. 5 of the 6 pre-pause neurological events occurred in women, and female sex was an independent predictor of treatment failure in the adjusted model. This is not a reason to deny PFA to women. It is a reason to be transparent, to follow the post-pause workflow rigorously, and to acknowledge that sex-specific outcomes remain incompletely resolved. The practical counseling script is this. About 1 in 3 drug therapy patients eventually required ablation within a year. About 1 in 5 patients in either arm had a serious adverse event over 12 months. Symptomatically, both groups felt better. The advantage of ablation was less detected AF, including AF the patient may not feel. Whether that lower burden improves long-term outcomes remains unproven by this trial. That is the balanced message. It respects the positive result without overselling it. Let's bring this together. AVANT GUARD is a positive trial. It shows that pulsed field ablation, used as initial rhythm control therapy in selected treatment-naive patients with persistent AF, reduces detected atrial arrhythmia recurrence and AF burden compared with a non-amiodarone antiarrhythmic drug strategy. The trial met both primary endpoints. The efficacy result was statistically strong. The safety endpoint met its pre-specified performance goal. The continuous monitoring burden signal was real and consistent across multiple thresholds. But AVANT GUARD is also only half the story. It does not prove that PFA makes patients feel better than drugs at 12 months. It does not prove that burden reduction translates into fewer strokes, less heart failure, less dementia, or lower mortality. It does not directly answer what to do in older patients with higher CHA2DS2-VASc scores. It does not fully resolve the female sex signal, and it did not test PFA against an amiodarone first strategy. The quick recap is this. AVANT GUARD supports first-line PFA as a reasonable option for carefully selected patients with treatment-naive persistent AF. The benefit is strongest for reducing detected AF burden, not for producing a clearly superior symptom or quality of life result at 1 year. The study pause matters because the trial resumed with a safer, more disciplined, but narrower protocol. Post-pause results should be applied to patients who resemble the post-pause population, not automatically to every persistent AF patient in clinic. And finally, the antiarrhythmic drug arm was not easy, low touch, or risk-free. Many patients needed cardioversion, hospitalization, dose titration, and eventual ablation. So the EP-Edge bottom line is this. The headline is real, but the counseling needs nuance. Read AVANT GUARD carefully. Use it clinically. Do not oversell it. That concludes this EP-Edge Journal Watch Special HRS 2026 edition on AVANT GUARD. All references and graphics are available in the LinkedIn newsletter, EP-Edge Journal Watch, and also on Substack at epedge.substack.com. If you have a clinical case where this framework helps or where it does not fit neatly, I would be very interested to hear your thoughts. EP-Edge is built to think alongside its readers and listeners, not simply at them. Thank you again for listening, for reading, and for supporting EP-Edge Journal Watch. I'm Dr. Sharma. Take care, and I'll see you in the next episode.